All right, let's dive into a topic that's absolutely essential for any ophthalmology trainee, ocular pharmacology. The eye is basically a biological fortress, one of the most protected organs in the body. So the big question is, how on earth do we get medicine inside? Well, let's find out.
So here's how we're going to break it down. First, we'll look at the eye's unique challenge, its natural defenses. Then we'll explore the clever ways we get medication inside. After that, we'll follow a drug's journey once it's in there. We'll check out the common tools in our pharmacology toolkit. And finally, we'll wrap it all up with a few core principles that you can take with you anywhere.
Okay, so before we can even think about treating the eye, we have to respect what we're up against. Just think of the eye as this incredibly well-defended fortress, designed specifically to keep everything out.
And that really brings us to the central question, doesn't it? The question that drives all of ocular pharmacology. How do you medicate a fortress? Every single decision we make about drug delivery comes back to solving this one problem.
These right here are the fortress walls. First, you've got a moat, the tear film, which is constantly washing away any would-be invaders. Then you have the cornea, which is this tough, multi-layered shield. And even if a drug makes it into your bloodstream, there are these internal gatekeepers, the blood-ocular barriers, that slam the door shut. And, to top it all off, anything that lingers on the surface gets quickly washed down the drain through the nasolacrimal system. It's a tough nut to crack.
So, if the front gate is basically sealed shut, how do we get inside? Well, this is where we get clever. This next part is all about the strategies we've developed to breach those defenses. It's all about finding the right secret passage. Every delivery route we choose is a trade-off. Topical drops, super easy for stuff on the front of the eye, but they really can't reach the back. A subconjunctival injection can sneak right past the cornea, but now you're talking about surgical risks, like perforating the globe. And for those deep retinal diseases, going straight in with an intravitreal injection is the most direct route, but it also carries the scariest risk, a serious infection like endophthalmitis.
Now here's a simple little technique that has a huge impact. It's called punctal occlusion. All you do is press on the corner of the eye near the nose. This little move closes that drainage duct and does two absolutely critical things. One, it keeps the drug on the eye longer, which boosts its effect. And two, it stops it from getting into the rest of your body, making it much, much safer.
And for some really specific situations, we have to pull out the specialized tools. You need a medication to work for months? We can use a sustained-release implant. Need to treat deep inflammation behind the eye? A periocular injection can get you there. And when an infection is just too big and bad for local treatment, we go systemic and attack it from the inside out.
So, we've managed to get the drug inside the fortress. But what happens next? Now we get to follow the drug on its journey to see how the eye deals with it, how it absorbs it, moves it around, and eventually gets rid of it. This whole story is the science of pharmacokinetics.
To put it really simply, pharmacokinetics is the life story of a drug once it's inside the eye. It answers 4 key questions. How does it get in? Where does it go? How does the body break it down? And how does it leave? If you understand this, you can really predict how well a drug is going to work.
A drug's chemical personality, you could say, determines which door it can use. The cornea's outer layer is kind of fatty or lipophilic, so fat-loving drugs can slip right through. On the other hand, water-loving drugs, hydrophilic ones, have a much easier time getting absorbed through the conjunctiva and the sclera, which is the white part of the eye. Now, distribution. Just because a drug is floating around in your bloodstream doesn't mean it gets a free pass into the eye. No way. The blood aqueous and blood retinal barriers are like these super selective bouncers at the door. They're there to protect the eye's delicate insides, which means a lot of systemic drugs just can't get to where they need to go. Because the eye is so good at flushing things out, we need ways to make our drugs stick around for a while. So what do? We can use thicker stuff like ointments or gels. We can do that nasolacrimal occlusion we just talked about. Or chemists can even fine-tune a drug's pH and thickness, anything to maximize the time it gets to stay on the eye and do its job. We've gone through the how and the why of getting drugs into the eye. Now for the fun part, the what. It's time to open up the ocular toolkit and take a look at the actual drugs we're using, day in and day out. First up, antibiotics. These are our workhorses for fighting and preventing infections. We've got classes like aminoglycosides, they're great broad-spectrum agents, and then there are the fluoroquinolones, which are absolute superstars at getting through the cornea to treat really nasty ulcers. Next, let's talk about steroids. These are incredibly powerful anti-inflammatory drugs, amazing for things like uveitis. But, and this is a really big but, they come with a major catch. Use them for too long and they can crank up the pressure inside the eye, which can lead to glaucoma. It's a classic risk versus reward situation.
Then we have NSAIDs, the non-steroidal anti-inflammatories. You can think of them as the safer, maybe a little less powerful cousins of steroids. They're perfect for managing inflammation after surgery. And of course, we rely on mydriatics. These are the drops that dilate your pupils, giving us that all-important view inside the eye for exams and for surgery.
And finally, a true cornerstone of our toolkit, glaucoma medications. Drugs like beta blockers and prostaglandin analogs are our frontline defense against one of the leading causes of blindness in the world. They work around the clock to lower eye pressure and save vision for millions of people.
Wow, okay, we have covered a lot of ground, from fortress walls to our medical toolkit. So now, let's boil it all down. Let's distill everything into the core principles you can take with you, not just for your exams, but for your day-to-day clinical practice. Believe it or not, this whole complex topic really comes down to just 3 things. If you can really get your head around these 3 core ideas, you'll have an incredibly solid foundation for applying ocular pharmacology in pretty much any situation.
And here's the whole framework. It starts with delivery, choosing the best route to get past the eye's defenses. Then comes behavior, understanding the drug's journey once it's inside. And finally, application, picking the right drug from your toolkit for the patient's specific problem. Delivery, behavior, application. Master those, and you've basically mastered the fundamentals.
Look, mastering these principles isn't just about passing a test. It's about what makes you a safer, more effective clinician. So the final question I want to leave you with is this. Now that you have this framework, how is it going to shape your very next clinical decision?